Hi, I'm Robert Parisian, orthopedic sports medicine surgeon at Mount Sinai Health System in New York City. I provide team and event coverage for Team USA, as well as the US ski and snowboard and USA fencing teams. And I provide finish line coverage for the NYC Marathon. Tonight, we're going to be discussing MPFC reconstruction. MPFC stands for Medial Patellofemoral Complex Reconstruction. And we'll get into more as we move forward and define that. And this is in the treatment of patellofemoral instability. Here are my disclosures. I am an associate editor for the Journal of Cartilage and Joint Preservation. I'm also on the editorial board for arthroscopy, as well as arthroscopy, sports medicine, and rehabilitation, and the Journal of Sport Rehabilitation. I serve on the research committees for the American Orthopedic Society for Sports Medicine, as well as the Arthroscopy Association of North America. And I'm on the Learning Center committee for the Arthroscopy Association of North America as well. I'm also on the media committee for the Society of Military Orthopedic Surgeons. I'm on the board of trustees for a nonprofit organization called Athlete Soul, who works to provide a transition for athletes post their athletic retirement and to help in that transition. I'm also an advisory board member for the Concussion Legacy Foundation, leading a concussion nonprofit organization. So a bit of my background, I always find it helpful that when we're discussing certain topics to go through a background and have better understanding of the speaker and of the discussion. So I graduated from Brown University as an undergraduate with an economics degree. I played football at Brown University and was fortunate enough to win an Ivy League title in 1999 as part of the Brown football team. I then pursued my post-baccalaureate pre-medical training and pre-health program at New York University here in New York City. I then pursued my medical training at Tufts University School of Medicine and graduated from Tufts University School of Medicine. I then went on to a orthopedic residency at Boston University, followed by a fellowship in sports medicine and shoulder surgery at Boston University. This was then followed by a fellowship in sports medicine and cartilage restoration at the University of Pennsylvania, which included time spent at the Penn Cartilage Center, as well as at CHOP, treating adolescent sports injuries. My final fellowship was in minimally invasive hip surgery at Harvard Medical School. So we are talking about lateral instability. You see this soccer player here. She falls down. She has this injury to her patella, and she is aggressively trying to relocate her patella here. And she is in a flex position, and that patella is out laterally. And if she simply extended, you could see that her patella would come back into a position. So again, patella instability, the lateral instability is a non-contact twisting injury, often associated with an effusion. And this really occurs in the second and third decades of life most commonly. So looking at the background and some of the literature of patellofemoral instability, this study looked at the incidence of first-time lateral patella dislocations. It's a 21-year population-based study. I'd like to draw attention to this table here in the graphs below, which show really an increased incidence in that adolescent age group, 14 to 18 years of age, for both male and female. If you look at the incidence cases in the columns on the left, and then incident rates in the column on the right, look down at the bottom, and you can see that peak incidence within that age group prior to 20 years of age, and certainly decreases significantly as you get into 30s, mid-30s, and up into 40 years of age. So what are the risk factors for patellofemoral instability? Well, there are modifiable and there are non-modifiable risk factors. Non-modifiable risk factors are defined by age and sex, and then osseous anatomy, which is trochlear dysplasia, which is classified by the de Jour classification. We'll get into that in a bit. Patella alta, which is a high riding patella. This can be determined by looking at the measurements such as the Caton de Champ, the insalsavadia, the Blackburn peel. And then miserable malalignment is a femoral anteversion, where your femur is pointed more anteriorly, and that can increase your internal rotation of your femur, especially in flexion. And this can contribute to patellofemoral instability or risk factor for it. Genial valgum, this is more of a knock-kneed rather than a bow-legged deformity. And this is represented by an increased Q angle. Now, external tibial torsion is external rotation of your tibia. And this is also one of the aspects of miserable malalignment syndrome. Now, looking at dynamic instability, you can look at hypermobility as defined by a Baton score, and we'll get into that in a bit following this as well. And then you can have VMO, which is vastus medialis obliquus hypoplasia or atrophy. So decreased muscle strength in your VMO can contribute to patellofemoral instability risk. Now let's get into the anatomy and function of the medial patellofemoral complex, at least the proximal aspect as well, because there was a distal MPFC, medial patellofemoral complex. So this is made up of roughly 60 to 60% the MQTFL, which is the medial quad tendon femoral ligament, and 40% of the MPFL, which is the medial patellofemoral ligament. And if you look at that image on the right, you can really see as they flip the patella upside down, you can see the articular surface of the patella north or superior. That's the quad tendon. You can see the MQTFL contributing about 60% to this MPFC, the proximal MPFC complex, and the MPFL contributing about 40% to this complex. Now, looking directly at the MPFL, looking at its anatomy, the average length is about 53 to 63 millimeters. It's mid-substance. It's widest at about 2 centimeters nearly. Its attachment on the patella, as you can see as you look at this image in the bottom here, the green is really where the MPFL is attaching, and it attaches roughly 22 millimeters from the superior pole of the patella and 34 millimeters from the inferior pole of the patella. Again, that green zone there. And you can also see it up in this figure up here. This is the MPFL coming from the medial aspect of the patella, this green zone. It attaches right here between the medial epicondyle, which is ME, and the adductor tubercle, which is AT. That's where the medial patellofemoral ligament attaches. And on the femur, it is roughly 15 millimeters from the medial epicondyle, and then roughly 10 millimeters from the adductor tubercle, right between the two. If you look at the MPTL, we're going now distal. So the distal MPFC, medial patellofemoral complex, the MPTL is represented right here, medial patellotibial ligament. So it connects the patella and the tibia. It's also represented in blue right here. And so that can be found about 3.5 millimeters medial and proximal to the actual patella tendon on its patella origin. Its insertion on the tibia is at the medial tibial tubercle. This is about 1 centimeter distal to the joint line and roughly an 8-degree angle from the patella tendon itself on the medial aspect. So you can see there's a bit of a gap here between the patella tendon and the MPTL, and that's about an 8-degree angle and attaches 1 centimeter distal to the joint line of the tibial plateau here. Now this is an italics vertical anteromedial portal incision, meaning when you're making your anteromedial portal incision, this is why I make a vertical one, because I do not want to make a horizontal incision because you will cut through that MPTL and the MPML, which is the medial patellomeniscal ligament, connecting the patella, the medial aspect of the patella distally, and the meniscus here, the medial patellomeniscal ligament. So you risk cutting these two structures if you're making a horizontal anteromedial portal incision, which is why I go vertical to save these two structures. So the MPFL, it functions as a primary patellar restraint in the first 30 degrees of flexion, as represented by the orange here when you're looking at where the patella is engaging the trochlea in flexion. And then the osseous structures really have the patella engaged in the trochlea at 60 degrees of flexion, represented by the green here with regards to our trochlea and our patella, which is, again, the patella flipped upside down, so you can see that articular surface. As we touched upon earlier, the Baton score is a measure of hypermobility and laxity. It is a score of 0 to 9. 1 is representative of your 90-degree extension of the MCP joint of the small finger. And the number 2 there, you can see the thumb coming down and contacting the volar aspect of the forearm. 3 is hyperextension of the elbows. 4 is hyperextension or recurvatum of the knees. And then 5 is if you can stand there with a straight legs and touch the floor, basically placing your hands flat on the floor. Again, 9 because each of 1, 2, 3, and 4 are for bilateral extremities, becomes 8. And then the final one there, as you can see in the 5th image, would just be 1, and such your scale of 0 to 9. Anything over 4 or equal to 4, we roughly consider to be in the hypermobile, hyperlax range, although there is no threshold range at this point in time. This here is a physical examination of a patient that has patellofemoral instability. And this is likely following a lateral traumatic patellofemoral dislocating event. This is how they would likely present. They may have a Baton score of greater than or equal to 4, again, representing some hypermobility and hyperlaxity. They likely will have a hemarthrosis, so that's blood in the joint. This is commonly seen after an ACL rupture, as well as a patellofemoral lateral dislocation. They may have tenderness of palpation about the medial retinaculum. Why is that? Because that patella has dislocated laterally, and so you have ruptured and torn the medial structures. So therefore, you might be tender along those medial soft tissue structures. You might have increased patellar translation of greater than 2 quadrants. So basically, you're going from the medial patella to the lateral edge of the trochlea. So greater than 2 quadrant translation. And then apprehension. So when you try to translate that patella, the patient apprehends. They don't want you to translate that patella laterally. And so they'll apprehend. They won't want you to do it. They'll guard against that. They have tinnitus palpation about the medial facet, because when the patella dislocates laterally, the medial facet is going to engage the lateral aspect of the trochlea. And so you have tentative palpation about that facet because you may have some chondral damage or defect to that medial patella facet. Patellofemoral crepitus may be present if you have a chondral injury to the medial patella facet, and then a J sign. A J sign is when the patella shifts outside and is no longer engaged. And so meaning when you're in extension, the patella may shift out laterally, and then when you flex, it engages the trochlea. And then when you extend again, it shifts out laterally. And usually this is more common in a patient who might have patella alta, which is a high riding patella. Quad circumference may be decreased compared to the contralateral side if you have VMO atrophy, as we discussed earlier. Knee range of motion might be limited just because you have a large hemarthrosis and the patient will be in pain. And then quad strength limited as well, secondary to the hemarthrosis and the injury. Hip flexion likely be within normal limits. Flexion internal rotation might be increased in patients that have miserable malalignment syndrome, because this is secondary to anteversion of their proximal femur. The hip flexion external rotation might be decreased due to anteversion. So again, when you have anteversion, you have increased internal rotation and flexion of the hip and decreased external rotation. And then abductor strength might be decreased secondary to this miserable malalignment in the injury itself. Medial joint line, possibly tender, secondary to a medial-based injury in that region. And it might be difficult to discern exactly if it's joint line tenderness or soft tissue tenderness. Your anterior and posterior drawer testing for your cruciate ligaments will be within normal limits. Lachman will be a 1A, so solid endpoint, no injury to the ACL, and a negative pivot shift, again, no injury to the ACL, and then no laxity or the varus valgate because you don't have an injury to the MCL or the LCL. So your collateral ligaments are intact as well. Imaging, I get full-length standing films in all my patients with knee instability, knee pain actually. It's very important. With patellofemoral instability, as we've been discussing. And this patient, for example, would have a mechanical access, which is through the center of the femoral head, and a line drop down to the center of the ankle joint. It's mechanical access. And this patient has neutral alignment through the center of the knee joint. Now, if this mechanical access is through the medial aspect of the knee joint, then that may represent a valgus deformity, or rather a varus deformity. Whereas if they have a mechanical access through the lateral compartment of the knee joint, this may represent a valgus deformity, which would then increase your risk. And we know that's a risk factor for patellofemoral instability. Weight-bearing films are important, and PA flexion films as well, to assess the joint space. Now, I like a merchant view. This is an example of a merchant view versus a sunrise view. And why is that? Well, the merchant view, you're not as flexed. And so the patella is not as engaged within the trochlea. And so I think you get a better sense of how your patella is actually aligned, whether you have patellar tilt laterally, if you have patellar translation. When you're two flexes in a sunrise, that patella is well engaged within the trochlea, and you're not going to have a great assessment of your patella. Now, there are multiple ways in which radiographically we're looking at an axial image here, how we can assess the patella as well as the trochlea. The sulcus angle is one that I like. Greater than 45 degrees would suggest some trochlear dysplasia. I also like utilizing the lateral patellar tilt angle or the patellar tilt angle in the bottom row to see if you have any patellar tilt. So in D in the bottom row, if you have increased angle, then it's representative of some lateral patellar tilt. And then you always want to look at displacement as shown in B in the bottom row. If you have lateral displacement of that patella, again, in the setting of a ruptured medial structure. So if there's a medial patellofemoral complex, you're going to see potentially some tilt and some lateralization. And you may also see some trochlear dysplasia, which would be represented by a greater sulcus angle and potentially a decreased lateral trochlear inclination, as shown in B in the top image. Now, this is trochlear dysplasia as defined by the du jour classification. If you look at the radiograph on the left, this right here is your intercondylar notch on a radiograph, and this is a perfect lateral. You need to get a perfect lateral with both the posterior femoral condyles are congruent with each other. It only looks like one femur here. So both posterior femoral condyles need to be congruent. Again, this is your trochlea here, and then this is your notch, and this is your trochlea. This is not supposed to cross. So here's your crossing sign in case of dysplasia. So you have the crossing sign on this one. You also have the supratrochlear spur in cases of increased dysplasia or worsening dysplasia, and then your double contour sign as well. So this is how a lateral radiograph can be very helpful. Now, defining trochlear dysplasia, type A is a shallow trochlea. Type B would be a flat trochlea. Type C would be a lateral convexity of the trochlea, and you can see how this would be easier for a lateral dislocation to occur. And then in type C, you also have medial hypoplasia of your medial trochlea. And then in type D, which also is consistent with a supratrochlear spur, you have a cliff sign. Now, looking at your patellar height, again, we were discussing that patella alta, and high riding patella is a risk factor for patellofemoral instability. This is ways on lateral imaging to assess your patellar height. Now, there are multiple ways in calculating this. The A is the Caton de Champ. A over B is how you calculate it, and normal is roughly about 1.2 or 1.3 ratio. B is the Blackburn-Peel, where B is measuring the articular surface, and A is goes straight down to a line that's perpendicular to that comes across the tibial plateau. C is the insula salvati, where they measure the entire length of the patella, and B, as well as from the nose of the patella to the tibial tubercle. And again, A over B is the ratio. I prefer Caton de Champ, but I usually typically measure two different ones. So Caton de Champ, looking at the articular surface, and then down to the tibial plateau, as well as insula salvati. Now, MRI is very important because you can identify soft tissue ruptures such as medial femoral complex ruptures with the MQ-TFL and the MPFL. You may also find subcondylar edema about the lateral femur in the medial patellar facet, because you can imagine when this patella dislocates laterally, you're going to have a lesion here on the medial facet, and you're going to have a lesion here on the lateral aspect of the patella. Rather than the lateral aspect of the femur. You may also have a chondral and osteochondral fragment, which is present in about 60% of cases, which is why I get MRIs in all patients with an acute lateral patellar dislocation. You can also assess version to see what their femoral version is. You can assess tibial tubercle trochlear group distance. Normal is roughly less than 2 centimeters. And then we'll get into how we calculate that there, but here's an example right here. You're basically looking to see how lateral your tibial tuberosity is in relation to the trochlear groove. And then there's another calculation called the TTTG over the patella length calculation. It's a ratio, and we'll get into that as well. And then CT is useful again for version analysis, as well as TTTG and TG to PL ratio calculations. Now, when assessing any injury with inside the knee, especially with patellar lateral dislocation, when we're concerned for lesions about the articular cartilage, I utilize the ICRS grading system. Now, normal cartilage is 0, ICRS grade 0 is normal. 1, you're going to have just superficial lesions in your articular cartilage, and there is no operative intervention for this. ICRS 2, you're going to have deeper lesions, but that represent less than 50% of the total depth of the articular cartilage. And then ICRS 3, you really get into greater than 50% depth of your articular cartilage. B, ICRS grade 3B, this is down to the calcified cartilage, but not through the calcified cartilage. 3C is through the calcified cartilage, and then 3D represents a blister included with addition of greater than 50% cartilage depth. ICRS4, you have violated the subchondral bone plate. This will matter when you're determining what sorts of cartilage restorative options that you have. Typically in the patellofemoral joint, I'm utilizing a cell-based procedure. Now, whether that be through a matrix autologous chondrocyte implantation or through a juvenile particulated allograft cartilage called de novo, and a one-step procedure. But you're going to do a cartilage restoration procedure, potentially if you have ICRS grade 3B and worse. So full thickness cartilage defects. So this is a patient that had a lateral patellar dislocation. You can see the subchondral bone marrow edema here on the medial patella facet because it's injury to the patella, because this patella came out dislocated laterally. That medial facet impacted here on the lateral femur, and then it relocated. You also had disruption of the medial patellofemoral complex here, including the MPFL and likely the MQTFL. So this is the lesions that you have, the subchondral bone marrow edema, the lateral femur, as well as the medial facet. You can see an osteochondral fragment here, lesion. So calculating the tibial tubercle trochlear groove distance, it's looking once again at the trochlear groove here, and then that distance to where the tibial tubercle is, because that represents your alignment of your patella ligament, and then the patella. If it's greater than 2 centimeters, it's considered abnormal, and you want to consider doing a tibial tubercle osteotomy. I typically perform an anteromedialization, but in the cases of patella alta, you may have to perform a distalization as well. Now looking at version, normal hip version is in A. The point is the hip is well located and appropriately located, and the foot is pointing directly forward. Now, if you're looking at femoral anteversion, I think the easiest way to think about this is you look at B and you look at the foot that's pointing directly straight forward, and you see that this femoral neck and femoral head is pointing anteriorly. This is femoral anteversion. When you locate this head appropriately, it turns the entire foot in. And so you have internal rotation with femoral anteversion, increased internal rotation of the foot with femoral anteversion. Now, if you're looking at retroversion, again, go to the normal foot here, retroversion. Normal foot's pointing straight. This femoral head and neck are pointing more posteriorly. Now, when this femoral head and neck are located within the acetabulum appropriately, as it is here, you set external rotation of the femur and then resultant external rotation of the foot. So again, normal, increased internal rotation with femoral anteversion, increased external rotation with femoral retroversion. Now looking at version, this is a great study that looked into and showed that nearly 80% of those with increased femoral torsion will walk with normal foot positions. So what does this tell us? Well, this tells us that we have a high specificity when it comes to in-toeing gait, meaning if patients have an in-toeing gait, walk with in-toes, they likely have increased femoral anteversion. However, if they don't, they still may have increased femoral anteversion. So it's not as sensitive, specific but not sensitive when you're looking at gait specifically to represent torsion. Now, when you're calculating anteversion, you need to know what you're calculating and ways in which you're calculating this. These are different methods here: the Lee method, the Ray-Karras, the Tomczak, the Murphy methods. They go from proximal to distal. Now, it matters how you're calculating this. Why? Because the more distal you go, the more the increase in version that you're going to see. So I prefer doing and calculating this through the Ray-Karras method, which is the second one there, B. It goes right through the center of the femoral neck. So when I have axial views of the femoral neck, I can draw a line at the widest point of the anterior and posterior aspects of the femoral neck, and I draw a line directly through that into the center of the femoral head. And this is how I'd calculate my version with regards to the proximal femur. And then, of course, you have to go and calculate this off of your posterior femoral condyles, and this is your total reversion. Then that's how you calculate it. This is a great study that evaluated version. And if you look at the bottom tables there with the red rectangular box outlining them, the different methods, the Lee, Ray-Karras, Tomczak, and Murphy methods. Again, Lee is more proximal, Murphy is more distal. And you can see as you get more distal, just by the way you're measuring it, you have increased version simply by your measurements. So when you're measuring this, you have to know what you're measuring, know what's normal for the type of measurement that you're utilizing. And then if you're going to do research and publish on this, you need to identify how you determined and calculated your version. So again, I choose the Vicarious method. You can see here too, there's not much difference between a CT and MRI calculations of version. Now, tibial version is a bit more straightforward. You're either going to do it off of this proximal tibia within these images more superiorly here. You either do it off the posterior condylar axis, or you do the transcondylar axis to the proximal aspect of your tibia. And then you measure that in conjunction with an axis across the center of your ankle joint distally. And then that will determine your tibial version. Now, the non-surgical management for first-time patella dislocations is sort of the standard of care, only if you do not have a chondral and osteochondral fragment, right? So you get an MRI, you analyze that articular surface of the patella, and if you do not have a chondral or an osteochondral fragment, you can manage these patients non-surgically. If you do, you need to manage them surgically and do an arthroscopic procedure to either fix that chondral fragment or osteochondral fragment, or debris to remove, and consider some sort of cartilage restorative procedure for this. Now, with these patients, they're going to have large hemarthrosis. I would consider aspirating the effusion. You have catabolic cytokines and enzymes there, matrix metalloproteineases that can be damaging to the articular cartilage. There's more literature that's coming out on this. And then you may provide short-term immobilization to decrease their effusion. Physiotherapy should consist of closed chain short arc quadriceps exercises, hip internal rotator stretching, as well as strengthening of the lumbar, the core, the hip abductors, the hip external rotators, as well as the quad and hamstrings. And then a J brace may also be beneficial for patellar stabilization, especially in the short-term to midterm period with regards to your non-surgical management. Now, this is a great study evaluating non-surgical management in patients with patellofemoral syndrome, but again, it can also be very useful in patients who have instability. And they found that combined hip abductor and external rotator strengthening, as well as internal rotator stretching, may improve pain and function in patients. So I think this is very important to utilize in non-surgical management. Now, looking at first-time dislocators, what are the risk factors in the time to recurrent ipsilateral and contralateral patella dislocations? A study out of Mayo Clinic. There are many studies out there, but I thought this was a great representation of this. The purpose of this was to evaluate recurrent ipsilateral patella dislocations as well as contralateral patella dislocations after first-time dislocators, and to try to evaluate some of those risk factors. Go down to conclusions here, and you can see that at 20 years following a first-time lateral patella dislocation, recurrent ipsilateral patella dislocations were 36%. So that same patella that you dislocated initially, at 20 years, 36% of those patients had experienced another dislocating event. And then 5% of those patients had realized a dislocating event on the contralateral, the other patella, the other knee. Risk factors they found were trochlear dysplasia that we discussed, the du jour classification, and elevated TTTG was an increased risk factor for recurrence after a first-time dislocation. Patella alta, again, high riding patella, and then young age at time of your first dislocation. Now, this is a great chart that looks at this. You look at the top right where the red box is outlined. This is the cumulative incidence of recurrent ipsilateral same knee dislocations following your initial dislocation as it looks at age. And you can see younger patients represented in that dotted blue line have a greater risk of redislocating as compared to older patients. And so you can look there on the x-axis, this is time to recurrent dislocation in years. And you can see that patients older than 18 at 10 years have about a 20% risk of redislocation, whereas patients younger than 18 are already over a 40% risk at 10 years of a redislocating event. So again, patients that are younger have a greater risk because they have more longevity, more life to live, and are also doing and participating in sports that are putting their patellas at a greater risk. Now, if you look at the bottom left-hand corner, this is a time to a contralateral dislocation. Again, much lower in the contralateral dislocations, but still greater in the younger age group as compared to the older age group. Now, a way in which to look at a patient's risk and stratify them has been proposed with the RIP score, the recurrent instability of the patella score. And so in this, they evaluated 81 patients to try to determine this risk stratification. 81 patients, mean age of about 20 years, so they were young patients, relatively an even split between male and female. They were followed for a mean of 10 years. These patients are followed out 10 years. 38 patients, about 47%, experienced an episode of recurrent instability. So 47 patients had a recurrent instability after a primary dislocating event, and 37% underwent a patellar stabilizing surgery. They statistically derived a scoring system called the recurrent instability of the patella score, the RIP score, and they utilized age, skeletal maturity at time of your initial dislocation, trochlear dysplasia, as well as the TTTG to PL ratio to try to predict the recurrent instability. And what did they find? They found that patients who have first-time dislocation of the lateral patella, they were able to classify them into a low, intermediate, and high risk categories based on the score, again, looking at age, skeletal maturity, trochlear dysplasia, and the TTTG to PL ratio. And they found that this long-term risk stratification holds significant potential utility clinically when you're evaluating high-risk patients for recurrent instability. This is a table of that, looking at age as a statistically significant factor, as well as dysplasia, the TTTG to PL ratio, and then your ALTA as well, looking at your Canton-Duchamp index. Now here is the RIP score, again, stratified into low risk, intermediate, and high risk groups. Now this is a survivorship percentages. So if you look at the low risk group, meaning you only have 0 to 1 risk factors, you had 100% survivorship. So meaning there was no patient in that low risk group that had a patellar dislocation following their initial patellar dislocation. Now the intermediate risk group, meaning you have 2 to 3 risk factors, at 1 year, 17% had a patellar redislocation. So that's why you have 83% here. So 83% survivorship, meaning 83% did not. At 2 years, 72% did not. At 5 years, 70% or 69% did not. Same thing at 10 years. So if you have intermediate risk, 2 to 3 risk factors, you have a 30% risk of a repeat dislocation at 5 to 10 years. And then if you're high risk, greater than 4 to 5 risk factors, then you can see here you have a much higher redislocation risk, upwards of nearly 70% at 5 years and upwards of 80% redislocation risk at 10 years. So now looking at surgical management of lateral patellar dislocations, these are all the management options here in categories. Again, for this talk, we're looking at the MPFC reconstructions. We're not going to be discussing tibial tubercle osteotomies or trochleoplasties. So a diagnostic arthroscopy is always performed. You may or may not do a chondroplasty, which is shaving of the articular cartilage and refixation of that cartilage is also an option. The MPFC repair, we'll discuss that in a moment. As another option is MPFC reconstruction, utilizing either an allograft or an autograft. And this may come with either a lateral release or not. We do have research right now that I'm looking into with my research colleagues here and out of Penn, looking at the contact forces if you do or do not do a lateral release with your TTO. And so we'll be coming out with that data hopefully sometime in the near future. Again, it's a biomechanical analysis. But then MPFC reconstructions with an MPTL reconstruction, so a proximal and a distal reconstruction is another option as well. So when looking at primary repair versus reconstruction, this study evaluated this directly. In the results section here, highlighted in the red, you can see that in the study, they identified 51 knees with isolated MPFL surgeries, reconstruction in 32 patients, and imbrication and repair in 19 of the patients. They followed them for 60 months. And the overall recurrent dislocations were significantly greater, they found, in the repair group of upwards of 37%. So those that underwent an MPFC primary repair had a redislocation rate of 37%, as opposed to those who underwent a reconstruction, they had a redislocation rate of 6%. So 37 versus 6%. So these authors concluded that there was significantly increased redislocation risk in patients that underwent a repair of the medial patellofemoral complex as to those who underwent a reconstruction. So again, when you're looking through the arthroscope and looking up at the patella, this is what you may find. You may find a chondral defect secondary to that injury pattern. This is my probe into one of those chondral defects. This can be debrided. This is likely this greater than 50%, probably not down to the calcified cartilage, as you can see here. Now, this is an image, a video of me translating that patella over laterally, and you can see it significantly translates over both sides, because the lateral retinaculum also does act as a check rein and restraint to when you have severe lateral patellar dislocation. But you can see that it tracks significantly laterally, greater than 2 quadrants here laterally. Now, with surgical reconstruction of your MPFL specifically, you look at Shuttle's point, and Shuttle's point is going to be determined radiographically on a lateral image, and you can see the different bony landmarks here. MPFL, as we said, is between the adductor tubercle and the medial epicondyle. MPFL is off the proximal aspect of the patella, and the MPTL and the medial patellomeniscal ligament come off the distal aspect of the patella in the same location. MPTL here is distal on the tibia, 1 centimeter distal to the joint line, as we stated. And then when you look at an AP radiograph, again, this is about an 8-degree angle from your patella tendon. Your MPFL is going to be just distal to your adductor tubercle and proximal to the medial epicondyle on AP imaging. Looking at your lateral imaging here, the Shuttle's point, which is your accurate location for the femoral attachment of the MPFL, is going to be just anterior to a line, the blue line there, which is the posterior femoral cortex line. So we just anterior to that. You're just distal to the line across the proximal aspects of the posterior femoral condyles. And then you're just proximal to this red line, which comes through your radiographic Blumensatz's line here, the most proximal aspect of Blumensatz's line. And so this black dot is your appropriate Shuttle's point. This is a case of mine where looking at the lateral imaging here, I'm identifying Shuttle's point with imaging. Again, a perfect lateral is obtained here with congruent posterior femoral condyles. Pre-drilling again, confirming that perfect Shuttle's point. Looking at it in 2 different aspects. So I look at it in 2 different planes with regards to my drill, and then you're going to drill from distal medial to proximal lateral to avoid your notch. Now, looking at the layers of the medial anatomy, so you understand where the MPFL resides and when you're doing an MPFC or an MPFL reconstruction. Layer number 1 is your sartorial fascia. This is going from superficial to deep. Number 2 is your MPFL, as well as your superficial MCL. And then your 3rd layer, your deep layer, is your MCL, your deep MCL, as well as your capsule. And so your MPFL is really in that layer 2. You want to be extra capsular with this reconstruction. Multiple ways in which you can reconstruct the medial patellofemoral complex. These are just a few examples here, and I'll show a few more as we continue to move forward. But again, there's utilization of autografts and allografts that you can use. And when you have multiple different reconstruction techniques, this usually means that there's multiple ways in which you can do this effectively. And so you look on the top left here, this is utilization of an autograft or an allograft, but this is an on-lay technique. You have suture anchor fixation in the proximal patella, either with a PEEK or a bioabsorbable implant, as you can see here, or you can have an all suture anchor here for an on-lay technique. And this would be more of an inlay technique where you're dunking the graft directly into the patella tendon. The patella. And then this is fixed either via interference screw fixation or biotenodesis fixation on the femur at the appropriate Shuttle's point, which you can see here with interference screw fixation being utilized here. And so the MPFC and a combined MPTL reconstruction can be performed, as I said, a proximal reconstruction as well as a distal reconstruction. The proximal reconstruction utilized here is likely a quad turn down reconstruction, reconstructing the MPFC, which is the medial patellofemoral complex, both the MQTFL and the MPFL, and then an MPTL reconstruction here down to the medial tibial tubercle. Now, medial patellofemoral ligament reconstruction techniques and outcomes. This is a nice review. And basically, as I said before, utilizing MPFL reconstruction The number one reason for failure is a malpositioned femoral tunnel, which is why we pay so much close attention to identifying Shuttlesworth point appropriately. Also, allografts and autografts may be utilized, and not one has been shown to be overwhelmingly beneficial as compared to the others. And so further literature and research is required in this regard. Now, this is my preferred reconstruction technique here, which we call the quad turn down technique. It is an autograft technique. Utilize 1 centimeter strip of the quad tendon. It's a partial thickness aspect of the quad tendon, and then you turn it down and rotate it over the proximal aspect of the patella, recreating a force vector that is between the MQ-TFL as well as the MP-FL, and then you have fixation on the at Shuttlesworth point on the femur. And I like to utilize a biotin screw fixation for that. You also have suture fixation here to stabilize the patella here. Again, I like this here because there is no fixation within the patella. You have decreased risk of patella dislocation, and you're also utilizing an autograft, which is the patient's own tissue. So you're not introducing any of the adverse effects of an allograft tissue for the patient. And here is a operative example of this case. You're utilizing this strip of 1 centimeter split thickness, or rather a partial thickness quad tendon, whip stitching it here, passing and shuttling it through, again, extracapsular and through the layers that we already defined, identifying Shuttlesworth point appropriately here in the femur, and then fixing it with a biotin fixation technique. Now, how do you tension? Many have described tensioning at 30 degrees of flexion. I, however, like the tension, and many others in the patellofemoral community, instability community, and restoration community, tension when the patella is well engaged in the trochlea. So I like the tension at about 60 degrees of flexion. And why is this? Because I don't want to over tension. I think over tensioning can be detrimental. It can also increase your contact pressures and forces on the cartilage of the patella as well as on the trochlea. And so I like the tension in 60 degrees when that patella is well engaged within the trochlea to decrease over tensioning of my graft. Again, this is a check rein. The medial patellofemoral complex is simply a check rein, so I don't want to over tension this. And then here is an example. Again, here is an example of the case after MPFL reconstruction, and you can see that the patella is well located within the trochlea and is gliding appropriately. There is no increased in lateral translation of that patella, as the median ridge articulates perfectly with the center of the trochlea. Again, this is following an MPFC reconstruction. So what are the outcomes of MPFC reconstructions? Well, this is an important study. I believe is important because it looks at the outcomes when you're with regards to patients that are dysplastic, because we don't have many trochleoplasties that are being performed, especially by sports surgeons. And this study was a nice one that evaluated 121 MPFL reconstructions, a young age group, 23 years, about 4.5 dislocations, typically before they had their surgery. 76% of these patients were female, so a large majority. And you can look at the TTTG ratios there were less than 13.5. Catello-Champ was normal. And then 90% of these patients had trochlear dysplasia of either B, C, or D, so even severe dysplasia in C or D. And the outcomes of these patients were that 74% returned to the same or higher level of the play, and then about 94.5% were actually able to return at 1 year. So some significant outcomes with regards to an MPFL reconstruction in patients in the setting of trochlear dysplasia. So these authors concluded that for these patients who do not have significantly elevated TTGG, so a TTO is not indicated, they don't have significant alta, so you don't need to distalize, then an isolated MPFL or MPFC reconstruction can be a safe and effective treatment for patellofemoral instability, even in the setting of a patient who has significant trochlear dysplasia with significant returns to play and return to sport. Now, return to play after an MPFL reconstruction. This is a systematic review. There's a lot of them out there, a number of them. I thought this was a nice one that really depicted what we are finding here with regards to our outcomes return to sport. And so the authors here evaluated 27 studies. Just over 1,200 patients were evaluated Majority were women, about 60%. Again, young age group, 22 years of age with significant follow-up. The return to play that they identified here across 27 studies, again, over 1,200 athletes, was 85%. So 85% of these patients were able to get back to return to play, return to sport. 70% returned at the same level. Now, it's important because I think when we're counseling patients and when patients are thinking about undergoing an MPFC or an MPFL reconstruction, although 85% get back, 70% get back to the same level that they were competing at prior to that. And so it's different. Getting back to sport is not the same as identifying those who are able to get back and perform at the same level they were performing at prior. And so I think this is great. However, both numbers are significant for patients to get back to return to play. They also found that in these 27 studies of over 1,200 patients, the recurrent instability rate was only 5%. So very low recurrent instability after a reconstruction of the MPFL. Now, here is my post-operative protocol for MPFC, medial patellofemoral complex reconstruction, multimodal pain management with a narcotic, typically oxycodone, as well as Tylenol and meloxicam, which is a potent non-steroidal anti-inflammatory, but it's nice you only take it once a day. Patients are on anticoagulation with a baby aspirin because they're immobilized. And I typically immobilize or have them protected weight bearing for about 6 weeks. And they utilize a brace as well. So they're toe touch and they utilize crutches. You can see progression here within the first 6 weeks with regards to their range of motion. Progress from 0 to 60 degrees is their goal at 2 weeks, 0 to 90 degree goal at 4 weeks, and then greater to 90 degree goal at 6 weeks is their goals for their range of motion. Again, I'm protecting them in their weight bearing for 6 weeks. Then at 6 weeks to 3 months, they enter phase 3 of their rehab process. They may unlock the brace at this time for ambulation. They can have a gradual transition of full weight bearing at 6 weeks, from 6 to 8 weeks, and then they can wean from their crutches, going from 2 crutches to 1 crutch and then to no crutch. They really want to make sure they're demonstrating a solid quad control so that they can control their extremity during their rehab process. And the goal is full range of motion return by 8 weeks. Strengthening is then begun with full weight bearing. And then you enter phase 4 at roughly 3 months. And this is phase 4 is roughly 3 to 5 months. Again, at this stage, you're full weight bearing without a limp. You're progressing your closed chain of patellofemoral strengthening. You're beginning treadmill walking, as well as progressing to balance and proprioceptive exercises appropriate. And then I introduce really plyometrics and jogging at the 4-month mark during phase 4 of the postoperative recovery. Phase 5, patients enter this at about 5 to 6 months. And then this is the sport-specific training and return to sport phase. So now that you're really increasing your rehab activity with high impact activities such as jumping and contact sports. And then this is really only being allowed at a point you have full range of motion, good strength, good proprioceptive control of your extremity. And then we're looking for 85% or the 90% limb symmetry between the two limbs before we return to sport. So again, it's my postoperative protocol, and I think I'd like to watch these patients very closely and make sure they're going to a very standardized postoperative protocol before they return to sport, and that they're actually ready at that point to do so. So it can increase those that return to sport, return at the same level, and decrease their chances at another recurrent dislocation. So thank you for discussing or being present for the discussion today for medial patellofemoral construction of the medial patellofemoral complex after a lateral patellar dislocating event. Find me via email, and also you can find me on social media. Thanks again for your time.